So let's go ahead and get started. So first, in terms of disclosures, I have no related financial interest to anything I'm going to be talking about today, and no conflicts of interest. The objectives today are to describe the process and goals of patient-centered health message tailoring, to discuss examples of evidence-based digital health programs really across the continuum of care, and to identify some opportunities for innovation in patient-centered digital health. So starting with the end, I think this is a really exciting time for everybody who's working in this field. There are these different areas of informatics. There's bioinformatics and what we're learning about the way in which our bodies work and the cells in our body. There's consumer health informatics and really dramatic changes in the ways that people are expecting to find and use information about their health. And there's the really rapid changes going on, somewhat forced, in clinical informatics with the adoption of electronic health record systems. And what's interesting is these three spheres of informatics are really starting to converge. And within that overlap space, we think there's a wonderful opportunity for improved communication, whether that's around promoting health, communicating information about risk, sharing and decision-making, or supporting treatments. In terms of some of those changes, these are just trends just to make sure we're all on the same page. Really dramatic increases in the past 10 years, 20 years in rates of internet access, so that over 90% of the US population now has internet access. 70–80% of that is actually broadband access. Mobile phone access, also we have 90% of the US population using mobile phones, and slightly over half of that population using smartphones. And a real change in way in which the people are using these resources, where just in this past year, we have more people doing searches and accessing the internet through mobile devices than they are through desktop or laptop computers. So these are just some big societal, cultural changes that are going on that I think influence the way in which we're going to care for patients going forward. And then, of course, in terms of that care, the real growth in the adoption of electronic health record systems, where almost 80% of hospitals and clinics now have a system. 50% of those will meet these criteria for basic systems. Many of those will provide patient portals and patients access to some portion of their health records online and be able to engage in at least some basic functions of communication with healthcare teams. So these are all major changes that are going on in the world. So, of course, whenever you're having changes in the world, the danger, of course, is that you become focused on the technology, right? And then when you're focused on the technology, you build the next coolest thing you can build. And definitely, I think in this world, it's not the case of you'll build it and they'll go, right? So I think it's going to be very important as we really try to move forward with patient-centered care to really emphasize the patient and the patient's experience and the patient's use of technology rather than the technology itself. And I think that's been a major theme of our center and maybe one major take-home point for my visiting you here today. So the first thing about being patient-centered is understanding what patients are actually doing. And so let's look a little bit more about internet use, but for patients that we care a lot about, which is patients with chronic disease or disabilities. And there it's a case of the glass being half empty or half full, depending how you think about it. Whereas 90% of people are going to be, online. What you'll find is that, particularly in the red bars, people actually doing health searches, searches related to health-related topics, whether they are in the general population, whether they're a caregiver, whether they've had a recent medical crisis, have a chronic condition, or one or more disabilities, you start to see that this number that was 80 or 90% is now more around 50 or 60%, or sometimes less than that. So realizing that there still is a substantial portion of the population that is not necessarily going to go online looking for health information. And that's something that we'll hit when we come back to some of the examples and our strategies for addressing some of these disparities. There's, of course, the continued digital divide in internet access, whereas these divides have narrowed over time. What you'll notice, particularly for older populations, those 65 and older, just over 50% are accessing the internet. Okay, so I think that we have to be creative in terms of thinking about really what are the right channels for engaging sort of a broader set of people than that. And these numbers become even more stark when you look at mobile access, whereas a lot of people indeed do have cell phones, what you'll see is the rate of smartphone use really falls dramatically, and that's what's in this first set of bar graphs on your right. Is that what you'll see there? Let's see if I can make the pointer work. Here and here, that less than 20% of adults over the age of 65 actually have a smartphone. So the notion that you'll develop a health app that's going to make a difference for broad swaths of people, just calls that into question a little bit, and really raises the idea that you need to have other channels for engaging your population. So let me tell you a little bit of background about our center and our approach to these sorts of problems and challenges. Our theme is really the right message for the right person, delivered at the right time and delivered the right way. We were founded in 1990. As Chris said, we're a P50 Center of Excellence in Cancer Communications Research, have had that designation since 2003. We really view ourselves as technology agnostics. We're a firm believer that there is no one right channel for reaching people. We will do things with social media and with mobile apps and mobile devices and telecounseling and websites, but we will still sometimes do things in print because lots of people still like to have something to hold in their hands. We'll tailor or personalize the print materials, but we'll still work in a print medium if we deem that that's the right medium for the population. We've worked in a range of settings, from healthcare settings out into communities, a range of populations across the age spectrum, from children's to older adults, for people who are essentially well, around screening, and then for people with advanced disease, both chronic conditions and cancer, and a range of topics from health promotion to medical decision-making and risk communication to disease management. And for that work, we've received sort of numerous awards in medical media and health media. Really, I think the secret to our success has been a firm commitment from the very beginning in sort of interdisciplinary work in terms of our product. How many clinicians are in the room? Can I ask? How many programmers are in the room? So we have this firm belief that you should never let a clinician in a room with a programmer unchaperoned, right? Because I think you can get some pretty scary things coming out of that sort of collaboration. I didn't mean to make total fun of you, but that happens sometimes. So we really think it's important when developing these programs that there's somebody in the room that's thinking about behavioral science and communication, and what is the language and message that's really going to resonate with an individual. We also think it's important to have somebody in the room that's thinking about creative design and graphics and art. What is the interface and experience going to be like for that individual? And I think that has been part of our approach to everything that we've done. And you'll see some examples of that. And I think it's been a really important part of what we've done. And maybe that'd be my message too, in terms of moving forward. It's really important to have a broad representation of that. And these experts, increasingly with patients in the room as well during the design process. Let me talk a little bit about tailoring and what I mean when I say the word tailoring, and then we'll go into some examples shortly. So tailoring really refers to a process where there's an assessment of individual characters that are relevant to a particular behavior that we might be trying to influence. Then we use algorithms, usually computerized algorithms, for taking that assessment data and generating an intervention message that's relevant to the needs of that specific user, and then developing a feedback protocol that presents that back to the user in a clear and vivid format. An example of this, you could think about sort of a message library with lots of potential information around information needs and our emotional states, uncertainty, relationships, or decision-making needs. That what we'll try to do is learn something about the individual and what they need and knit together for them a personalized educational prescription that directly addresses what that individual needs. The goals of tailoring are to grab attention, to help people engage in the effortful processing of that information, to elicit what we call self-referential thinking, having them think about how relevant that information is to them and their lifestyle and their behaviors, and then to create an emotional response. And that if we do that and target the appropriate theoretical constructs around self-efficacy or attitudes or normative beliefs, we're going to be more successful in helping people to change their behaviors. The goal, of course, is to have impact, and that is, in true public health mathematics, the combination or the multiplication of your efficacy, how effective are your programs, and the reach of your programs. We know, of course, there are some types of interventions which are very efficacious, good one-on-one counseling being an example of that. But it's very hard in this day and age, both for economic reasons and human resource reasons, to be able to scale something like individual one-on-one counseling. Of course, there are bad one-on-one counselors who are low efficacy and low reach as well. There are public service advertisements that are higher reach, tend to be lower efficacy. Maybe group-based health education is a little bit broader reach. We think that we can get to a sweet spot of high efficacy, high reach interventions through these individually tailored computerized interventions. Just want to take a brief digression and just say a few words about exciting work that we're doing in our center around tailoring cognitive neuroscience. And what we're really trying to do is understand when we personalize or tailor a message for an individual, how is that affecting the processing of that information in the brain? And so a standard paradigm would be to do an assessment where we would have people in, for example, a brain scanner, looking at brain activity and trying to understand when they have a low depth versus high depth tailored message, how is the brain responding differently? And what we've shown here, this is a specific example in the case of smoking, but it's been shown for other preventive behaviors around physical activity, sunscreen use, diet, that when we personalize a message, so it's very tailored and the person feels that it's very relevant for them, we preferentially activate areas of the brain that are associated with self-referential thinking, so the consideration of the meaningfulness of the message to the individual, and also associated with memory formation. And that when messages are constructed the right way and we activate these areas of the brain, the people where we activate these areas of the brain, they're more likely to go on and be successful changing their behavior. And so we're using this as a new approach in terms of helping us to refine our message tailoring work. So with that as a background, I'm going to walk through a couple examples. But before I do that, maybe I'll take a quick pause and open it up for questions. Was there any questions or clarifications about anything I presented so far?
The example of the circles where you shift from focus on technology to focus on the patient. Right. Can you give an example of your own thinking that is changed by that shift?
So an example of this would be we recently built a program for prostate cancer survivors, right? So the goal when it started was, well, let's try to develop a system that could help assess men with prostate cancer who receive treatment for their symptoms and side effects that they're dealing with, and then present them with self-management strategies. And so there was a fairly elaborate plan to develop an online resource for doing this. And then we sat down and we talked with some patients and their spouses who said, well, I don't think he's really going to do that. We really want to have something on paper. Right? So this is an allusion to that. So what we developed was an alternative system where we were using automated phone programs, so an IVR, interactive voice response or phone program, to actually call patients and assess their symptoms. And then based on their symptom priority areas and strategies that they were interested in learning about, we would create a tailored, personalized newsletter that would then get mailed out to them. So they would receive personalized materials in print form after an IVR assessment. And that would be an example of, trying to adapt the intervention channels and technologies to the user's needs. Yeah?
On the slide right before this one,
okay,
where we were talking about the brain scans,
yes,
how do you generalize that information to the general population?
Right. So there's a couple different approaches. Separate talk, which I'm happy to come back and give if you're interested at some time in the future. So there's a couple different ways in which cognitive neuroscience works, and I'm not a cognitive neuroscientist. But one of them is what they call sort of brain as predictor for population. So what we'll do, for example, that wasn't this example, but I think it's going to be an answer to your question, is we will put people in the scanner, maybe 30 people, see how they respond to, how their brains respond to different health messages, okay? Let's say it's a media campaign. Then we'll talk to them in the traditional approach to say, which of these ads did you find engaging or interesting? So we have their self-reported response of the relevance of these messages. We actually have their brain's response to exposure to these messages. And then we can go on and look and see which sets of ratings better predict the population's response to a media campaign. Right? And so what we find, which is kind of interesting, is that the brain's response is actually a much better predictor of the population's response to a media campaign than an individual's response. And the short answer to that is, and maybe this rung true for me when it's explained to me this way, is that we don't always have complete conscious access to all the things that influence our behavior, right? So that's advertising and marketing 101. And what these techniques do is they let us start to dig into what are some of the unconscious influences of behavior and how can we sort of tap into those in terms of helping to shape our health messages.
How are you sustaining and growing the operation of the center? I mean, do the product designers, engineers, business people, medical people live in those respective schools? How is it funded? Is it funded? Is it philanthropically funded? Is there any form of revenue to fund it organically?
Okay, so we're in the process of transformation. It's probably the best way to say it. Throughout the bulk of our history, we've been a grant-funded center where I would say we've been successfully and continuously funded going on 20 years now for this work. The center has spawned one startup company called Health Media, which spun out. It was founded by Victor Strecker, in case you know the name, which was bought maybe 4 years ago to be a major part of Johnson & Johnson's wellness initiative. So that's happened. I'm currently one of the faculty champions, they call it, for digital health for the University of Michigan as part of the new Fast Forward Medical Innovation Initiative, which largely is trying to fix, you could call it, the broken pipeline of ideas from research out into practice. There's a couple components of our strategy. One big component is to get better research clinical integration locally so that we can turn the University of Michigan into a living laboratory for the type of work we're doing, and then develop programs in such a way that they actually can be disseminated or commercialized afterwards. So.
And the source of the grants?
The source of the grants is largely NIH. We do get we've been sort of diversifying with foundation funding. We've been actually pretty successful with getting PCORI funding as well. Okay, I'm going to go on, well, once again, we'll have time for questions spaced throughout. So I just wanted to go over a couple examples of programs. Michael and Chris were kind enough to share with me a little bit of information about some of the priorities here around health outcomes and prediabetes and hypertension. So I thought I'd give a couple examples that address healthy lifestyle that I think would be relevant for those initiatives. I heard about the work in practice sustainability, so I thought I'd share an example of a program developed at the University of Michigan to really support collaborative care. And I know health disparities is an issue that's come up before, so just two examples that deal with health disparity sorts of issues. Okay, so around healthy lifestyle, the first one is, we'll call it, actually it's a pretty old program, but with some interesting things. This is not just one program, but I'll share with you a line of research led by Carolyn Richardson, who is a faculty member in family medicine at the University of Michigan. So she's developed a program, and we developed the initial versions of this with her called Stepping Up to Health. It's funny, it was basically Fitbit before there was a Fitbit. The notion was that you could have automated internet-mediated pedometers with goal setting and personalized feedback. So does it work, and what are the ways to sort of refine that over time? And so this is the essence here. And what we found in the initial trials of this work is what other people found is that, yes, indeed, when people are wearing these pedometers, they're uploading the information, receiving personalized feedback, you do indeed see increases and sustained increases in activity, both in terms of total steps, and for those of you who are exercise mavens in the crowd, this concept of bout steps is periods of, say, I think it was 12 minutes or more of intensive exercise. And there's been some debate about, is it the total number of steps or these bouts that are most important? The good news is both of them tend to go up when people are tracking their steps. And so let's take that as the base case, that these devices tend to be beneficial. What are ways to make them more beneficial? And one specific question that Carolyn was interested in asking is, what about the role of online communities? When you attach these pedometer programs and the data to an online community, what do you find? And so this was a randomized trial to look at that issue. The online community would be similar to the other program, except there was a pretty basic online community feature where people would write things like, I'd be lost without my new friend, my pedometer. I plan to keep wearing it as a reminder and incentive to continue walking. Between me and my Labrador, Spot, the pedometer, I should be successful. I've enjoyed adding incentives as a daily goal. Or yesterday I participated in a 5K walk, something I never would have done before the program. I wasn't the fastest, but I wasn't the slowest either. So these are the types of messages that people are sharing in these online communities. This was actually a randomized trial. The target population were people at high risk of diabetes, coronary disease, obesity. They were sedentary, ambulatory adults, and they were randomized to either have the program or the program plus connection to the online community. The major finding was increased engagement in those people that were randomized to the online community, where you had much higher rates of continued uploading of data into the site if people were randomized to be participating in the online community component. And that while that was happening, there was no decrement. The amount of activity stayed the same. So it wasn't just that you had people uploading the absence of activity. People continued to upload and continued to stay active throughout the process. The conclusions from that was that these online communities do work to improve program retention. They're able to do that without actually decreasing the level of activity. The effects could be significant, particularly if implemented at large scale, and it seemed to be most useful for people that had low baseline levels of social support. The next study we looked at, continuing sort of this exploration of social features related to pedometers, it's what's the effect of having private versus public goals. And this is a study looking at these factors. You can imagine it could be positive in terms of the offers of social support and social accountability. It's also potentially negative. You could have spamming, embarrassment, you could have undermining type messages, and negative comparisons where people actually become discouraged because they see everything that somebody else is doing. And so this was a collaboration on top of what was happening with the Fitbit, where people would set daily goals and then they'd be informed whether or not they met their goals. And it was, again, a randomized trial where people were randomized to receive either the program where they would make private commitments to exercise, or ones in which their commitments would be linked to Facebook for commenting, right? And so an example of what this would be, Paul was actually the principal investigator. Met my commitment last week, yay, 5 days over my daily steps target, just like I said I would. Next week's commitment, 5 days over 10,000, and then people will be commenting on that. Or maybe he's not successful, fell short last week, 2 days over my steps target, even though I committed to 4, and then an exchange of messages about it being discouraged and receiving some potential encouragement. So if you have this, what happens? And so what we found, really interesting, is that there's a difference in both the creation of commitments and the setting of goals and the fulfillment of those goals. So what you see is that if people are in a private situation, they're much more likely to set goals. 89% will set goals, but they're actually less likely to meet them, right? If you're in a public setting, you're not as likely to set a goal, but if you do set a goal, you're more likely to meet them. So there's some countervailing forces going on here, which I think are quite interesting. And what we really see going on, there's a balance between personal autonomy and social accountability in terms of the setting and fulfillment of these goals. And I think that's just something important to keep in mind as we start to try to have people share more and more of their information. It's not necessarily assured that the net result is going to be positive. I think we have to look at this carefully as we go forward. The next set of studies with Stepping Up to Health really started to ask the question, so it's great for people that are well to be exercising. Can these programs work for people with health conditions or limiting health conditions? And this is an example of a program adapted for people with back pain, where the Stepping Up to Health program was adapted with specific messaging for people with back pain. And it was, again, a randomized trial. Just to point out, this is pretty significant back pain. So people, to get into this trial, had to have persistent back pain for more than 3 months, a very sedentary lifestyle. 40% of them would say they were in poor or fair health on the 5-item scale, and almost half of these people were on chronic narcotic medications for their back pain. Okay, so not the typical set of people that you think of using sort of Fitbit or Up or these fitness programs. What we found was that there actually was an marginal increase in steps, but more importantly, there was a clear decrease in disability in people who were engaged in these programs when they started with significant back pain. So that we found that to be very encouraging about the broader use of these programs. We also asked the question whether or not these sorts of programs could be helpful for people with lung disease. What we know about pulmonary rehabilitation is that it's very important in reducing hospital admissions mortality, but once again, back to the issue of scalability, access to pulmonary rehabilitation programs is actually quite limited, both in the VA and on a national scale, and this was a study that was done in the VA. So once again, took the program, adapted it for people with lung disease, and then randomized people to receive either a control or the intervention with the online pedometers and the personalized goal setting. What we found there was that we were able to decrease symptoms of dyspnea, shortness of breath. This is the red line decreasing more than the blue line for the intervention group. And also increase rather than decrease the average step counts for people with pretty severe lung disease. I think I might have skipped over about 20 to 30% of this population is oxygen dependent going into a study like this. I'm now going to talk about a program that we've called the Realu, and this is a story of failure and success, and hopefully a little bit more success after that. But it was illustrative for me. These are some programs that I was more involved in building. Oops, I went the wrong way. There we go. Okay, so the original goal of the Realu was to help young adults stop smoking. And so we spent a long time doing our qualitative work with young adults, collecting stories and understanding their motives for smoking and their reasons for quitting. We put a lot of time and energy into building a website to help communicate that information and engage young adults. And what we showed is that we could not pay young adults to come to a website about stopping smoking. Right? And we would hear very interesting stories like, oh, smoking is a problem for people who are smokers, which I'm not, even though I smoke. And I think the best thing we heard is that, if I was ever to become addicted to cigarettes, well, then I would quit. And so this was the challenge that we were facing in terms of engaging young adults in an important sort of health promotion activity. Here it's smoking, it could be prediabetes, it could be other things. So we really went back to the drawing board, and we did a little bit like what the tobacco industry does. Is smoking is not about smoking. Smoking is not about the cigarette. Smoking is about everything else that's going on in somebody's life. It's what they're doing for fun in their social life, what's causing stress, what do they think about health, what's going on in their life, why are they in school, and really what's happening in this transition from the present heading toward the future, right? So with those thoughts in mind, we redesigned the site with a broader focus on college life. We actually hired 9 student writers to do an online college life magazine. They also provided peer support via email, and rather than just talking about smoking, we started talking about the broader things in somebody's life and what we called contextual smoking triggers. So rather dealing with the issue of friends and smoking, we started to talk about friendship and who are your friends and what makes somebody a friend. We talked about drinking and smoking, and we looked at drinking behavior and alternative activities. Stress and smoking, we tried to identify what were some of the underlying drivers of stress in this population around time management, sleep, diet, and exercise. We never really found a compelling health message, I have to say, around smoking, but there was a message around attractiveness and dating that we ended up highlighting as part of the site. This is what it came back as, and rather than just being about smoking, there were, we'll call it broader interest stories around dating, around working out, and so, for example, here's an article that was written on Valentine's Day as part of the online magazine about kissing strategies and techniques, right? So keep your eyes closed, right? Nobody wants to be stared at. You really freak your partner out when you do that. I don't know if that's actually true. Relax your lips and your tongue. And by the third one is checking your breath and some incorporation of a message around smoking and trying to avoid smoking. So this was the first sign that we might have been onto something. So this is just a comparison of ongoing participation in the online College Life magazine compared to the Stop Smoking website. And this is where we don't need fancy statistics to show that these two curves are likely different. Where we had high and sustained retention in the online magazine over 20 weeks. We then went ahead and did the randomized trial and showed that compared to a control condition, this online magazine with the integrated stop smoking messages achieved much higher quit rates, both on self-report and also with a low level of biochemical validation. So our take-home message from that is that you can do a stop smoking program for young adults, but not as a stop smoking website. It was more successful going to a College Life magazine format. You could reduce the point prevalence of smoking, increase 30-day abstinence, and also amongst those who are continuing to smoke, increase their reported readiness to quit. Yes?
Was the College Life magazine written specific to the University of Michigan, or was it generalized?
So this was at the University of Minnesota, and it was written for the University of Minnesota.
Local language.
Yeah, so there was local language, local events. So whereas we felt that was successful, there were a couple limitations. So first, this was a multi-component intervention. So there were this magazine format. There were also online peer emails, and we weren't sure which of those parts of it were making the difference. It was pretty limited from a technical standpoint. There was a lack of diversity. It was a single campus. So we went on to do a follow-up study where it was actually a 3-arm study where people were recruited more broadly from young adults nationally, not just those in college. People were randomized to either get a general lifestyle website, a lifestyle website with tailored messaging around smoking, or that tailored messaging plus an online peer support as well. It's interesting how fast the world changes. When we finished the first project and wrote the grant for the follow-up project, between the time we wrote the grant and got funded, something called Facebook happened, and then something called YouTube happened. And we said, like, oh my God, we can't do what we said we were going to do. We have to do something different than we said. So we eventually developed a slightly different approach where we turned the online stop smoking program into an online personal health makeover show. And people would select an avatar to host the show for them and lead them through a personal transformation of goal setting. And so people would come in, they would select an avatar, and then this is an example of what the avatar would do for them every week. We also sort of, rather than have it be about health per se, we did sort of a takeoff of various magazine covers. So this is the week that we addressed smoking, and we chose to do it by doing a takeoff of Yoga magazine. It sort of worked.
I want to breathe much better. I want to breathe much better. Feels so good. Serious inhalation here. This week, we shall see what we can do to breathe our way to a more liberated incarnation. Let's check in. Let us know how the world has been treating you.
And so there was a really intentional, there was some attempts of humor, obviously, in doing this, but there was an intentional desire for us to create a space for people to attend to their own health needs. And that was sort of inherent in everything we were doing here. People were asked to set goals around smoking, also around physical activity, also around eating breakfast, and also about moderating their alcohol use. There was also an online peer coaching component where, depending on what goals people set through the online interface, they would receive a personalized video from a peer coach that they had chosen, encouraging them and offering support in terms of meeting those goals. And these were individually recorded, personalized videos that were uploaded to a secure site. Once again, we felt we were successful in terms of identifying and engaging format. We had high rates of adherence over all 12 weeks of this project. And then we were also successful, again, in achieving our main outcome of encouraging smoking cessation, where people that got the general informational lifestyle site, 11% of that group quit smoking, compared to 23% in the group that received the sort of avatar online support. If you added the peer video support as well, this went up to 30%. But what was even more interesting to us is that we were finding that the the theme that we chose of an online personal health makeover actually was resonating with our users more than we thought. We originally thought about this as an engagement strategy, but what we found is people were actually making changes in their alcohol use as well. What you see is that in terms of episodes of binge drinking in the past 30 days, binge drinking being 5 or more drinks at a single occasion, we decreased that by the end of the intervention by almost 2 days, the equivalent of 1 weekend per month of less binge drinking in this population. In terms of days of exercise, this is self-reported bouts of exercise of 20 minutes or more, increased by 4 to 5 days in the intervention group, so almost an additional week of exercise. For our dietary intervention, we actually chose eating of breakfast as a relatively simple change that we thought there was some evidence suggest would be beneficial and would be hopefully relatively easy for young adults to implement. We increased breakfast eating by almost a full week per month in this population. And then if you look at sort of the combined issue of multiple behavior change, what we found was in the blue bars are those people that got the control condition. Half of people made no improvements, and then the others made either 1 or 2 or 3 or 4 improvements, and that basically flipped. So for the intervention group that also had the peer support, you had half of that group, almost half of the group, making positive changes in 3 to 4 areas. So this idea of transformation across multiple health conditions and health behaviors, we were really excited in finding. I think it's relevant for some of the work you're planning in the diabetes space, for example. Yes. So the question was, can we try to understand what's the relative benefit of using an avatar, a digital character, versus having a live person involved? At least for the primary outcome, that would actually be shown here, which we can start to do because we had the 3-arm design. These would be the rates of stopping smoking, where it would go from 11 to 23 with just the digital character. And if you add the person on top of the digital character, you can get another 7 to 8%.
And one.
Yes.
But going back to your point about tailoring not only the right message, but the right population, I can see how avatars might be attractive in the college-age population that you studied. Have you also looked at the influence of avatars and their use in different age groups?
Yeah, so there's a really interesting research group called Intelligent Virtual Agents. It's an IVA conference. So there's a group actually that studies exclusively the use of these digital characters for a range of things around education, around business. This year's conference focused on health. One of the leaders in this area is Tim Bickmore at Northeastern University. And he's done a lot of work with these agents, with older populations and populations with chronic disease. And what we find actually is that because people don't have to interact with keyboards in quite the same way to interact with these characters, they tend to be very well accepted in older populations, particularly populations that have low health literacy, right? Most of us probably here are quite literate. We can read faster than we can hear. And listen to something. And so for people that are really highly literate, it seems to be a little bit of a wash whether or not these characters are all that beneficial. For people with lower health literacy, these characters seem to be especially engaging and beneficial based on Tim's work. I'm going to go here, then here, then there. Yes?
So on these programs that you're developing, has there been any effort to work with individuals in clinical practice and to try to introduce these types of programs into the clinical practice setting?
So I was talking about our desire to transform our center. And so what you just said was one of my main goals when I took the job at the University of Michigan, was to do this kind of integration. The challenge was when I showed up at Michigan, like 6 months after I showed up, we were implementing a new electronic medical record system, right? And so this is an example of innovation in one area sort of canceling out innovation in another. They really needed to focus on getting the EMR implemented, running 24/7 and stable. And they needed to do that, and that's a several-year process for any of you who've been through that. And maybe I'm being overly optimistic when I say it's a several-year process. Maybe it's an ongoing process. But I think we've reached the point at Michigan now where they're ready to start thinking about this additional innovation. And so we're on the cusp of doing that right now and creating these sort of connections. The program I'll tell you about next around enhancing engagement. That has been integrated into clinics and actually been implemented statewide in several programs as well. I said I would come back over here.
Actually, my question is a little bit related to that. These are very small sample sizes in a very limited time frame, so there's a hard stop at the end of the 12-week period.
Right.
What happens after that? And the next one that you're going to talk about has actually been implemented, so that answered that part of the question.
Right.
Had any follow-up after the 12-week period on any sustained like communication with the program, or people kept up with the results?
Right. So I think you're identifying a great point. For these studies, we do have some, not this one in particular, but some of the others where we've had the online programs, we have follow-up out to a year showing similar results, so that's encouraging. Usually we don't follow people for more than a year, and that's basically a constraint of the funding mechanism and what tends to be accepted in terms of an NIH trial. We do what is sort of accepted there. I'm not making excuses, but I'm sort of making an excuse. I think what we need to move towards is a sort of new model of doing this research where we're really more integrated into clinical practice and follow people over a longer period of time. And they're doing, this is what we're trying, related to the prior question, we're trying to set up an infrastructure that lets us do sort of more live comparative effectiveness work with digital health tools. Yes?
I was really struck by the idea that you can't get to not smoking by talking about not smoking.
Yeah.
And it's making me wonder, we have the very focused efforts right now to avoid diabetes, to control blood pressure. And it almost seems like what you have shown is that you have to step back from that and talk about healthy living. Or some other bigger goal under which not smoking or controlling your blood pressure or not getting diabetes is a path to achieving this life goal. I'm not sure how to integrate that into work, but I'm just wondering, am I taking away the right message here?
I think that's part of the message. Right.
Aiming at it?
I think that might be part of the message. We actually had a really interesting conversation at lunch about how some of this work and other sort of work in health behavior might affect some of your strategies around preventing diabetes, right? And so the two specific areas we talked about is the role of self-affirmation in health behavior change, and also the strategy from within motivational interviewing of identifying core values. And so those of you anybody familiar with motivational interviewing, that's a general technique. So it's basically an abbreviated counseling strategy to try to help people resolve their ambivalence about making a change in their behavior. A key step in motivational interviewing is trying to identify what somebody's core values are, whether that's being a good parent, being a good spouse, being good in the eyes of God, whatever those might be, and then connecting that to whatever the behavior change might be. And so that's sort of what we did in this program. It's definitely an effective strategy and a core principle of motivational interviewing. I think it suggests that you do need people, the challenge with prediabetes is there's a basic lack of awareness that you have to address, right? But when it comes to actually motivating change, I think it can be beneficial to tie into some of these other values. The last thing I'll say, and I'll get to your question, is related to this concept of self-affirmation. Self-affirmation is really engaging people in exercises to try to identify their personal strengths. And it's believed that if you do an affirmation exercise, such as asking somebody to write about or list their personal strength and write for 3 to 5 minutes about how they exhibit that in their life, that will make them less defensive when they receive a potentially threatening health message. And I would say being told that you might be developing diabetes is a potentially threatening health message. The normal sort of ego defensive response is to put up your walls and to try to push that message away. If we can build somebody's ego strength as part of receiving that health message, maybe they're more likely to receive it and maybe more likely to react to it in a positive way rather than a purely defensive, negative way. So I think it's an open question, but there's lots to talk about after this talk. Yes?
I don't know if this is where you were going, but for the long-term effects of
your studies and the interventions.
Uh-huh.
Have you looked at what happens when they don't have access to their avatar anymore? Or, college kids can't log into their college system, and now they don't have that avatar mom telling them to eat their veggies?
Yeah, so we haven't looked at that. And that would be I'll spin that up into a broader comment about some of the limitations of NIH-funded research, right? The analogy would be your word processing program, whether you use Word or some other format, right? So nobody ever did a randomized trial of Word versus a typewriter, right? Yeah. Nobody said, here's Word, it works, and then it's frozen like that, it never evolves, right? So all of these commercial software programs, they evolve in version over time to get better and better, right, as you were sort of talking to. What we don't have right now and what we're trying to develop is a model or a mechanism for the creation and upgrading of these programs on a more continual basis. Yes?
I have one more, and it kind of ties back to what he asked about the smoking cessation and the going direct at that message. Do you think it had to do with the demographic and the general attitude of college-age student versus an adult who might be facing a more serious involuntary condition where smoking is voluntary?
I think the young adult population is particularly problematic, but defensiveness is probably not purely limited to a young adult population, would be my answer. All right, so I want to talk about the collaborative care work that was done with the CarePartners program. So John Pate was the principal investigator here. So this program is based on interactive voice response. Essentially what's happening is the system is calling the patient, asking them to report on symptoms and experiences of care. There's a feedback loop to the clinicians and also a separate feedback loop to family members. How many, maybe I'll just ask the quick question, how many of you out in the audience have ever been a caregiver for somebody who, or involved in the care of somebody who had a serious health condition? All right, so now the qualitative work, up here is really good and down here is really bad. How helpful was the healthcare system to you in fulfilling that role? Yeah, so most people are going to be pretty low, and with one notable exception, which is great, but we want to make that a more common experience, right? I would say a lot of care in the US is delivered by friends and family, and we collectively as a healthcare system don't do a great job engaging the expertise and talents of that network of people. And this program was built specifically to try to address that issue. So it's been developed, many versions have been developed in the area of heart failure, chemotherapy, chronic pain, diabetes, hypertension, depression. And an interesting thing, and this is results with over 2,000 patients with a variety of chronic diseases. And what's shown here is just the likelihood that people actually respond to the automated phone call. And the interesting thing here, two interesting things. One is the rates of response are almost all above 80%. And the other interesting thing is that it actually goes up with age. So rather than the engagement decreasing as people get older, they're more likely to engage and stay engaged in these programs. So I want to show you the results of several studies that will all follow this basic design where we have a target population with a chronic disease or health condition. They're enrolled and randomized to either receive the IVR system assessment with alerts that go to the clinician, or the IVR assessment with alerts going to clinician and the caregiver. So it's kind of a step care model in terms of the overall design. So in patients with congestive heart failure, what we found is that the program definitely increased medication adherence. This is the probability of people taking their medications. And what you see is on the right side, hopefully nothing's going to explode here, the right side, your right side, is that over time, when people are engaged in the IVR program with alerts to clinicians and family members, that the adherence is higher and it continues to increase over time, whereas in people who are getting just the clinician alerts, it's lower and tends to be decreasing over time. And that's going to be sort of a common theme here. Yes?
How do they get the alerts, and what kind of patients are these?
So these are patients with congestive heart failure.
Socioeconomically?
So
Are they inner city, urban, or?
I don't know specifically for this program. I think these were patients that were seen at the VA, so they're going to be an older population with slightly lower socioeconomic status.
What's the alert? Is the alert more than a text?
So the alert that would go to the clinician would be an alert related to, it would go, in this era, it was happening through fax, which is still kind of the common denominator for getting into clinics these days, I have to say. For the family member, it was probably an email at that time.
So where I was going with this is Hopkins has been working on this Baltimore inner city population, 600 plus thousand.
Yep.
And they're realizing in their mHealth initiative that everybody's got a cell phone.
Yes.
They don't have smartphones.
Yes.
The only way they communicate is text.
Yes.
The distressed populations.
Yes.
So, it's really low-level technology.
Yes.
That's why when the alerts were.
Yeah.
And what the target population was, because us, we're smartphone people.
Right.
We've got multimedia, all kinds of channels at work.
So this program in particular, the technologies are simple. So it's going to be plain language, it's phone and text. Text either via text messaging or text via email. There's not going to be a lot of pretty pictures other than the results here because there's not really anything to see. So this was the likelihood of this improvement of symptoms in these patients with congestive heart failure. So the likelihood that people would be short of breath. What we see in the clinician group is an initial improvement when the alerts are given, but then that falls off, whereas you see a sustained increase in those groups where the family and friends are engaged as well. In patients with depression, around medication adherence, the same sort of thing. This becomes a general theme. The blue line are the alerts to the clinician, where you see an initial improvement in adherence, but then a decrease over time. With the family members, there's an increase, and then a continued increase over time when the family members are engaged as well. In patients with diabetes, once again, in terms of medication adherence, there's higher medication adherence, particularly in the last 6 months of the intervention, for those that are getting caregiver support as well. And then in patients with back pain, you see a developing and enlarging trend toward increased steps. I think it was about 3,000 to 4,000 steps per day different, which is about 30 to 40% of your daily steps goal. So that probably is going to be sort of a meaningful number of steps difference in there. Even as a non-expert, I can say that. So that's the work that's going on in the sort of increased engagement care management space. So the last program I want to talk about is what we call the I Decide program. And so this is a program that was we did in response to a call from AHRQ to help disseminate diabetes guidelines. And the basic approach here is we thought, well, the people that are in most need, the target population here was African Americans, Latinos, and inner city Detroit with poorly controlled diabetes. To your question earlier, we didn't think these people were going to go online looking for information about diabetes or how to care for their diabetes. But the federally qualified health clinic in Detroit was already sending community health workers out to make visits. But those health workers were going out with pamphlets and folders and binders of paper. What we wanted to do is build an interactive tool that they could take with them on an iPad and use to engage the patient in conversations when they visited in their home. And so the program was developed. It's actually tailored. This is just an example here how the graphics are tailored to be reflective of the ethnicity of the patient, whether they're Hispanic in the upper frame or African American in the lower frame. And I was told, at least, in Detroit, African American community, there's actually, it's a small nuance thing. There's sort of dying. There's sparrows there, which we were told in this community had particular relevance around rejuvenation and health. So we tried to incorporate that kind of messaging as well. And then we developed some video materials to try to better explain what is diabetes in a way that hopefully people could understand. And this was done in collaboration with the community health workers and patients in inner city Detroit. We actually have a paper out describing sort of the connections between community-based participatory research and what we call agile or patient-centered design. And we'll see if the video plays. It did earlier, but I don't know what's going to happen now.
What exactly is diabetes? When a person has diabetes, it means they have too much glucose or sugar in their blood. To help explain, let's first look at how the body normally works. Let's take a closer look. Imagine that you have just eaten a great dinner. First, the food gets ground up in your stomach. Then, the bits go to your bowels, where your body takes out what it needs, like glucose and vitamins and minerals. The glucose goes into your body, so it can be used for energy or stored for later. If your body has more glucose than it needs, it stores the extra in your liver and fat cells. We'll talk more about this when we talk about how your medications work.
Anyway, so what would happen there is the community health worker and the patient would view this video together and then use it as a starting point for conversation about diabetes and diabetes management. So it was really, you could think of it as creating an environment for more productive conversations. We also had other sort of interactive tools. Here's one part of it where people could set a goal in terms of their hemoglobin A1C and be able to see what their risk of different complications from diabetes would be, depending on what A1C goal they set. And then there was a big part of this around helping people assess their medication choices. So we actually built off work by Victor Montori, who's done work with issue cards around diabetes and other medications as well. And we created a digital version of that where the patient could identify what were the issues that were important to them and see a profile of the different types of medications related to that issue and then start to prioritize and make choices. All of this helped them develop a new plan for their diabetes care that then was communicated by the community health worker back to the clinic and used in follow-up visits. We also, a common strategy we use is we developed something called a tailored testimonial. So these are fictional characters that have health conditions similar to patients who are trying to overcome similar challenges, and we basically tell a story of that individual. And they might match in terms of gender, in terms of barriers they face, like getting refills, or in terms of other important characteristics. And so what we showed in this study was greater satisfaction with information, both around clarity and helpfulness of information in the iDecide tool versus the print tool. And short-term, 3-month follow-up actually showed an improvement in the proportion of patients that actually met their A1C goal of less than 7, where it actually increased in the intervention group, whereas it was decreasing in the control group.
Thank you, Dr. Ahn. You presented a lot of data from showing randomized trials. Can you spend a little time talking about the creative design process, the use of designers, the use of programmers and other disciplines, and what that process looked like in the chemistry among the teams leading up to these detailed trials?
Yeah, so it's a really fun process for those of you who have been engaged with sort of work at all. So when we start a project, we always bring together, ideally, the sort of content expert, usually it's the PI or the investigator, ideally sort of a member of the user population, a designer who thinks about the user's experience, a communication specialist, and a programmer. And we'll spend days to weeks just hashing out different ideas. A lot of initial prototyping done on paper, a lot of collection of response to that, and then we'll start to move toward a build process where, in the life of a project, we ideally want to get sort of a working prototype done sort of halfway through the project, so we can start to get some response and feedback. It's just a blast of an experience when we do it. And the thing I have to say, the creativity comes from these other members of the team. I think I can say this. Well, it's this for internal consumption of the video, right? It's like people think they have great ideas, but until they actually talk to the people that are going to be viewing what they see, you don't really know what's a great idea or not. Yes?
So I wonder if you could think with me about translating what you've done working with patients and communicating with patients to communicating with healthcare providers and teams. Because as you mentioned, one of our groups is working on practice transformation. And so, and we're creating digital resources.
Right.
And we want to take from what you've told us and extrapolate that and apply it to communicating with the healthcare providers themselves. So I know that's not the area you've worked in, but I wonder if you can think a little bit with me about what lessons you've learned that we can take to that work.
Right. I think I think an important thing to keep in mind is that members of the healthcare team, nurses and physicians, they're people too, right? And so just like somebody who's thinking about trying to lose weight or trying to exercise, they have core values as well. And if we can try to tap into their core values, or maybe their core personal values, or maybe their core values related to professional identity, that trying to tap into those and tie those into whatever the rest of our messaging is going to be, I think could be potentially important. The other thing we've started to do, this is a project we're starting to do around lung cancer screening, trying to approach the best practice alerts around lung cancer screening in a different way. Many of you are probably familiar with a study done showing the benefits at some harm to some people and some false positives, but the overall survival benefits of lung cancer screening. What's interesting is that through further refinement of algorithms, you can actually identify people who are going to benefit the most and people who are likely to benefit the least. Forgive me for going into the weeds, right? Let's say the number needed to treat just all comers for a lung cancer trial is like 200 to 300 is my recollection. But with further refinement, you can get that down to some groups of people where the number needed to treat might be 20 and others where it's 3,000, right? You could potentially personalize a best practice alert system where physicians could set for themselves, based on their practice patterns, the threshold of number needed to treat where they would like to receive an alert, right? And then implement that. And then it'd be interesting to look at how would they respond differently to an alert that they knew they had set the threshold for, rather than a generic alert that they had no input into. That'd be one example of sort of engaging the user and trying to reflect the user's values in the messaging as a first start. Other questions?
Yeah, thank you very much. It's really inspiring to see such tailored work to different. So my question is more around, I have an app and a wellness platform from my insurance provider, from my physician provider, from my wellness, from my gym down the street, my treadmill even has an app to it. So as I navigate as a patient or just a general healthcare consumer, does your center do any research around who's winning right now in terms of enrolling and actual use of these type of, I know this might be more towards a smartphone generation, but do you track and monitor this usage and who's winning?
So we do not track that ourselves. We've actually recently, so let me take a step back and then come at your question sideways, but I think I'll answer it. The basic answer is no. One of our core features right now is not to track what's going on in terms of the public's or people's use of the various apps. I would say we don't track that, and I would say nobody's really tracking that, and there's a huge unknown about how useful a lot of the apps are that are out there. And that's something that a lot more attention needs to be paid for. I do know there's some work in the commercial world. There are some companies that are trying to establish a business model around app curation, right? So identifying the best in breed apps and being able to recommend those to people. And they've approached us to start to have a conversation about how could our science and our understanding of health behavior change be contributed to the app curation process. So it's something we're looking at for the future. We're not currently doing it, but I think it's an exciting area.
Interesting, thank you.
Yes?
In your focus groups and your conversations with potential users, did you have any feedback from people saying, this is just one more thing I have to use?
And if you sense any pushback on having one more application to use, one more thing to maintain, one more thing to follow up, if you had those responses at all, how did you counter those?
So we have not had that many of those kind of responses. Some of it might be the types of programs we've been developing recently, which are really around sort of cancer chemotherapy or other sorts of things where I forget if it was you or somebody else said, I think it was you, because you're saying, well, these aren't kids, they're adults. They're adults with a health condition. There's some intrinsic motivation for them to engage, and then you're just trying to meet that need. So a lot of our programs have been that way, and in that sense, people have tended to engage a little bit more. So we haven't heard it that much, but I think that we will hear it. And I think that's where, looking at some of the more generally available platforms, things like what Apple's doing with their Health Kit or what Samsung is doing, where we're tapping into a more general platform where some of this can happen, and to really do this integration behind the scenes across apps is a really interesting area going forward.
Right, and our audience is primarily physicians and healthcare workers who have multiple platforms, payer systems, things they have to deal with. So,
I take it back. When you're dealing with healthcare providers, you hear that all the time.
Yeah. So thinking about it from our perspective, that's where I think about that most.
Right. So the death knell there is any sort of parallel system where they have their working system and they have another system they have to go to do what you want them to do. They're just not going to really go that often. Right. That's the challenge.
Great. Thanks for being here. A quick question. You spoke about for the projects and the teams that you compiled to go to market.
Yeah.
Could you speak a little bit about the time duration that you had all of them together to kind of ramp up and decide what was the format and what was the content that you thought would be most valuable to be successful once you were?
So the development time for these projects, of course, varies a lot depending on the project. Usually it's rare for us to be able to get from beginning to end of a project in less than a month. We'll usually have teams of 4 or 5 people working on a project. Each team, maybe this is too much detail, but I'll share it with you. And so when we put together our teams, we use sort of an agile development process where they're sprinting. Each team will work on probably 2 projects, so they'll spend 2.5 days a week on one project, 2.5 days a week on the other project. And most projects will be anywhere from 3 to 9 months, longer if it's a really huge project. The initial concept, we really want to get down within that first month. And what we find is that sort of Agile is a very time-intensive process. Oftentimes, it can be a little bit overwhelming for principal investigators who are busy, faculty or clinicians doing other things. So we're trying to develop a softer sort of launch phase where we get some maybe lower level but really deep engagement with the principal investigator, so when the development team starts, they really have everything they need to get going at that time. But the initial conception, we want to get out within the first week to month, and usually the way we do that is by having kickoff retreats where the whole team comes together for several days continuously. So for maybe like 3 to 4 days, they're going to meet for 8 hours a day on that project, going through and iterating multiple times during that period.
Okay, I think we have time for one more brief question.
So one of the questions, physicians are currently being recognized for their efforts in chronic care management and transitional care management from the inpatient setting to the outpatient setting.
Yep.
And I heard a lot of your presentation on data from patients in improving and preventing health problems.
Right.
But one of the needs for data is in the chronic care management area and helping them to get meaningful data into the practice to identify the patients who are already fragile. And I was wondering if there's any work being done in that setting, kind of along the lines of the practice transformation question.
Right. So there actually is a version of the CarePartners program in the field being tested right now to try to prevent readmissions after hospitalizations. I don't know the results of that yet. But it is, I agree with you, it's a huge area that we're sort of looking at intensively.
Well, let's please give Dr. Ahn a warm thank you.
Thank you.